وحبيبتي الأستاذة الدكتورة سونيا الشرقاوي بورسعيد ومع أهل بورسعيد وكل الناس الجميلة دي. هاخد حضراتكم في رحلة كده للبيدياتريك اندوكراين كلينيك. هحاول أخليها لايت شوية لأن أنا حاطة فيها كيس برزنتيشنز as if إن إحنا يعني رحنا كده زورنا البيدياتريك اندوكراين كلينيك وشوفنا كيسز، ويا ريت نخليها انتراكتيف. ساعدوني في الدايجنوسيس والمانجمنت. So welcome to the Pediatric Endocrine Clinic. As we all know, the symptoms of endocrine disorders are sometimes vague, and that's why we need to follow any clue when dealing with pediatric endocrine cases. And it's very important to avoid the pitfalls and to watch your step when dealing with children with endocrine disease for better diagnosis and treatment. So let me take you to a zoom into the pediatric endocrine clinic, and let me show you a taste of our golden tools that we use at our clinic. We have the standing and sitting stadiometers, the infantometer, the growth charts, of course, the orchidometer, the labs, and radiology, including the bone age and other radiologies. And what we do is that we fit the pieces together and think properly to reach the proper diagnosis and treatment, which is not always easy in every case of pediatric endocrine. Now, let me start gland by gland. And of course, the maestro is pituitary. Now, help me in this case. This is a 6-year-old girl who came with proportionate short stature. Birth weight and length are normal. The girl was very short, -4.5 standard deviation. Very poor growth velocity, 2 centimeters a year. Doll-like face, excess abdominal fat, and the IQ is normal. And looking at the growth chart, she was born normal. And in infancy, she was fine. And then she started to decelerate the height at the age of 3 years. Celiac screening, thyroid, adrenal functions, everything was normal. And when we did the growth hormone provocation by 2 tests, it came low, and the IGF-1 was very low, and the bone age is delayed. So simply, what is the diagnosis? A very straightforward case. Yes, thank you very much. This is isolated growth hormone deficiency, a very typical case. And looking at the growth hormone IGF axis, we all know that the hypothalamus secretes growth hormone releasing hormone, which stimulates antipituitary to produce growth hormone. On the other hand, somatostatin inhibits growth hormone secretion, and the growth hormone acts on the liver, stimulating IGF-1 production. And there is a negative feedback by the growth hormone at the level of antipituitary and hypothalamus. Also, IGF-1 inhibits pituitary and hypothalamus and stimulates somatostatin to avoid excessive growth hormone secretion. So, logically speaking, the pathophysiology of growth hormone deficiency is a defect either at the level of hypothalamus or antipituitary or the liver. And the effects of growth hormone deficiency vary in different age groups. In childhood and puberty, it's important for linear growth, and therefore large doses are needed. In adulthood, it's important for metabolic purpose, like being lipolytic, increasing the bone mineral density and the muscle mass, and therefore lower doses are needed, and in between there is transitional period. Now, what happened with this little girl? We started growth hormone, and the response was really beautiful, and she gained a lot of height and reached a good final height. So the conclusions here are: patients with growth hormone deficiency are born with normal weight and length, and they have normal growth velocity in infancy. Growth hormone deficiency is diagnosed by 2 growth hormone provocation tests, never by random sampling. Response to growth hormone therapy is better when started early. and growth hormone is sometimes continued for life in adults with growth hormone deficiency for metabolic purpose. The second is a 5-year-old boy who came with proportionate short stature, low birth weight and length, very, very short, poor growth velocity, doll-like face, and excessive abdominal fat. And looking at this child, we first thought, oh yes, it looks like growth hormone deficiency, except that it's more severe, and it started since birth. Now, doing the labs, everything came normal, and surprisingly, when we measured the growth hormone, it came very high instead of being low, and the IGF-1 was low. The bone age was very much delayed. What's your diagnosis of this case? High growth hormone, typical features of growth hormone deficiency, low IGF-1. This is a case of growth hormone insensitivity. Would you like to give growth hormone for this child? Yes or no? No, of course we do not, because this is receptor defect. So the answer here is IGF-1 therapy. So patients with growth hormone insensitivity have a similar phenotypic features like growth hormone deficiency, but more severe. They are born SGA and short. They have a very high growth hormone and low IGF-1, and this is the differentiating point. And of course, the treatment here is IGF-1 and not growth hormone. Now, let's go to the posterior pituitary. This is a 1-month-old female, a known case of hollow prosencephaly with agenesis of the corpus callosum. She came with polyuria, failure to thrive, persistent fever, weight loss, shock, dehydration, and the weight and height were below the normal. Now, looking at the lab profile, the sodium was very high, plasma osmolality was very high, the urine osmolality and the sodium were low, and the rest of the endocrine glands were normal. What's your diagnosis? Yes, hollow prosencephaly with central diabetes insipidus. And in newborns, it's very tricky. The only presentation could be fever of unknown origin and failure to thrive. And the baby was given desmopressin as a treatment. So suspect diabetes insipidus in any case of hypernatremia and polyuria. High plasma and low urine osmolality is the most important diagnostic feature. Desmopressin is the treatment of choice in the central type, and start with a very low dose to avoid SIADA, or syndrome of inappropriate antidiuretic hormone. Now, leaving the pituitary, let's go to the gonads, the testes and the ovaries, because growth and puberty are closely related. As we all know, delayed puberty is lack of breast development by the age of 13, lack of testicular enlargement by the age of 14. Pubertal arrest is more than 5 years between the first and the last sign of puberty. And finally, amenorrhea is lack of menarche by the age of 15 and sometimes 16. Delayed puberty is classified into 4 main categories: either constitutional delay in growth and puberty, hypo, hyper, or eugonadotropic hypogonadism. The last 3 are pathological and require treatment, and the first is a physiological condition. And by far, constitutional delay is the most common cause of delayed puberty that could be excluded. Now, looking at the pathogenesis of delayed puberty, it's either hypogonadotropic hypogonadism. Here, there is low GnRH, low FSH-LH, and low sex steroid. While hypergonadotropic hypogonadism, there is a problem with the gonads secreting low sex steroid, and by the feedback, you're going to find high FSH and LH. So if you have low FSH-LH, this is hypogonadotropic hypogonadism. High FSH-LH, this is hypergonadotropic hypogonadism. And in both of them, you're going to have low sex steroid. So if you want to differentiate, you need to do gonadotropins. This is the differentiating point. Now, let's take the story of this 14-year-old boy who came with short stature and delayed puberty. His father gave history of being short and then catched up his height after having delayed puberty without treatment. And this is the chart of the boy. He was normal, and then he became a short child, And then he decelerated his height more with delayed puberty at adolescent age, as you see. The boy was found to have microcytic hyperchromic anemia, lowish calcium, low vitamin D, thyroid and celiac were normal, and the GnRH stimulation test revealed low FSH, LH, low testosterone. And the bone age is delayed 10 years, and the height age is 10 years as well. So we're having a boy with delayed puberty, and the bone age is exactly equal to the height age. What's your diagnosis of that adolescent boy? Yes, thank you very much. This is a typical constitutional delay in growth and puberty. And here we added vitamin D, calcium, iron, and zinc, nutritional support, and the boy gained excellent height and normal puberty, growth spurt, and achieved a very good final height. Right now, he's taller than his father. So constitutional delay in growth and puberty is the most common cause of short stature and delayed puberty, more in males. Positive family history is usually present. Patients must have delayed bone age, which is exactly equal to the height age, and this is the most important diagnostic point. Patients are clinically free, they have low FSH, LH, and testosterone, and we need to reassure the parents that the child is going to reach a very good final height without treatment. We need just nutritional support. Sometimes we give a very low dose of sex steroid to initiate the growth spurt if psychologically upset. Another totally different story is this 13-year-old boy who came with secondary growth failure. He's short, -2.5, pubertal arrest, headache, squint, attack of focal convulsion, and a clear deterioration in the school performance. And this is the chart of the boy. He was completely normal, and then secondary growth failure developed, as you see here, 6 months ago. And please respect secondary growth failure very much. It's very important. So his free T4 TSH are low. This is central hypothyroidism. Growth hormone by 2 tests, very low. Growth hormone deficiency. The bone age is delayed. So yes, it looks like panhypopituitarism. And because the golden rule says whenever you have more than one pituitary defect, you should look for the rest, we did the cortisol, ACTH, very low. Central hypoadrenalism. And GnRH revealed low FSH, LH, and testosterone. So again, this is hypogonadotropic hypogonadism. So it's definitely acquired panhypopituitarism. And if you put the lab data with the clinical picture of the child, what's the urgent investigation in that boy? Yes, thank you very much. MRI, sella turcica. It should have been done even earlier than this stage. And look what we found, low-grade astrocytoma. So any case of secondary growth failure or pubertal arrest must be thoroughly investigated. Very important. Exclude brain tumor in any child with panhypopituitarism. And any case of panhypopituitarism must perform MRI, sella turcica, even in the absence of neurological signs. What about this girl? This is a 13-and-a-half-year-old girl who came with short stature and delayed puberty. Her birth weight and length are very low, swelling of the dorsa of hands and feet, mathematical problems at school, and she develops recurrent otitis media. And look at the chart of the girl. She's short since birth, infancy, childhood, adolescence, until the time I saw her. Her thyroid and growth hormone are normal, the celiac is negative, the bone age is delayed. And look at the GnRH. Very high FSH, LH, low estradiol. What's the type of hypogonadism? Is it hypo or hyper? Yes, hyper, gonadotropic. This is a gonadal defect. And she also had partial horseshoe kidney. What's the missing investigation in such a girl? Yes, thank you very much, karyotype. It's very important to do karyotype even in the absence of dysmorphic features. And the karyotype came 45X Turner syndrome, as you see. And here she was given growth hormone and sex steroid. She catched up her growth and puberty. She's doing very well right now. Now, karyotype must be done to any girl with short stature and delayed puberty. Turner girls could have normal growth hormone because they have growth hormone resistance rather than deficiency, so they need higher growth hormone doses. Turner girls are more liable to autoimmune disease like Hashimoto thyroiditis and celiac. What about the other side of the story, precocious puberty? It's the appearance of any secondary sexual characteristic before the age of 8 in a girl and 9 in a boy. And if you look at the pathogenesis, it's either central precocious puberty when the axis is activated, you're going to have high GnRH, high FSH-LH, and sex steroids. In case of the peripheral, the axis is not activated, and there is autonomous secretion of sex steroid either from the gonads or adrenals. So you're going to have suppression of the FSH and LH, low FSH and LH. So again, if you have high FSH, LH, this is central. Low FSH or LH, this is peripheral. Again, we rely on gonadotropins and not on the sex steroid to diagnose the type. Now, let me share with you this 3-year-old girl who came with bilateral breast enlargement. Her height is normal at the median. She's Tanner breast stage 3, and she has normal genital appearance. Her FSH is very high, LH is normal, estradiol is high as well. The bone age is normal, it's not advanced. What's your diagnosis? Is it precocious puberty or premature thelarchy, for example? Yes. Hey, Dr. Tarief, تعال معنا بقى. Okay, this is premature thelarchy. Would you like to treat or wait? Wait. Thank you very much, Dr. Mu'taz. So, premature thelarchy is isolated breast development before the age of 8 without any other signs of puberty. Girls will have normal height and bone age. FSH is high, LH is normal, and this is very important, and estradiol is high, and usually it's regressive. Sometimes it could progress to central precocious puberty, so it's very important to follow up such cases. And this is what happened when I saw the girl 2 years later. She came with accelerated growth. Look at the height, jumped. And the Tanner stage increased before P2, A1. Look how she looked like after 2 years. And when we repeated the GnRH, FSH was high. This time, LH is high. Remember, it was normal. And the estradiol is high. The bone age is advanced. It wasn't advanced before. So what happened to this girl? Is it still premature thelarchy? No. It progressed to central precocious puberty. Would you like to treat or wait? Yes, thank you very much. We have to treat. We cannot wait on such a case. So some cases of premature thelarchy progress to central precocious puberty. They will have accelerated height and bone age, high FSH, LH, and estradiol, and of course the treatment is long-acting GnRH analog. What about this boy, a 4.5-year-old boy who came with bilateral testicular enlargement? There's no history of drug intake. He's very tall compared to his age. His testes are very large, 8 ml, and remember, if testicular size exceeds 4, this is a pubertal size, so this is a very large testis for a child. And the growth chart showed accelerated growth. FSH is high, LH is high, testosterone is very high, the bone age is very advanced. Is it central or peripheral? High FSH, LH, what do you think? Yes, thank you. This is central precocious puberty. And in a boy with central precocious puberty, what's the most important investigation? Yes, thank you very much. You have to do MRI, Celatosica, because in most of the cases in boys, you are excluding a tumor. And this is what we found. We found hypothalamic hamartoma in this boy. So any boy with central precocious puberty must perform MRI, Celatosica, even if asymptomatic. Hypothalamic hamartoma is benign hypothalamic tumor, but it's the most common cause of central precocious puberty, especially in boys. And the treatment is long-acting GnRH analog because this is a very sensitive location for surgery and it's benign. What about this 5.5-year-old girl who came with bilateral breast enlargement, menarche, long bone fracture? She's very tall. She has café au lait patches. Tanner stage breast 3, no pubic and axillary hair. And this is the chart. As you see, she's very tall for her age. Look at the GnRH, FSH low, LH low, estradiol very high. And the bone age is advanced. Is it central or peripheral precocious puberty? Thank you. Yes, peripheral precocious puberty. And we did an ultrasound. We found ovarian cysts and bony dysplasia, which is the cause of fractures. So what's the most probable diagnosis of that girl? Thank you. Yes, McCune-Albright syndrome. So exclude McCune-Albright in any girl with premature menarche. The classical triad is peripheral precocious puberty, polyostotic fibrous dysplasia of the bone, and café au lait patches. And the treatment here is anti-estrogen or aromatase inhibitors plus bisphosphonate. Of course, you do not give GnRH analog because it's not a problem with the axis. Another 5-year-old boy came with enlarged penis and pubic hair. He also has painful erections. He's very tall. His penis is 8.5 centimeters. He has pubic hair P4. Testes are prepubertal in size, 3 ml. His GnRH revealed low FSH, low LH, high testosterone, with a very advanced bone age. Is it central or peripheral precocious puberty? Yes, this is peripheral precocious puberty. And all the adrenal panel came normal, but when we did an ultrasound, we found a mass and confirmed by CT scan, and this was a very large testicular tumor, and surgery was done here and proved to be left testicular Leydig cell adenoma. Look how dangerous precocious puberty could be. So because small testicular mass could not be palpable, any boy with precocious puberty must undergo testicular ultrasound. Also, Leydig cell tumor is an uncommon cause, but should be thought of. And remember that after removing the mass, it could shift to central precocious puberty. Now, let's leave that and go to the adrenal glands. This is a 1-month-old baby who was referred to me as a male with bilateral undescended testes. There is ambiguous genitalia, as you see, pigmented genitalia. The baby came shocked, dehydrated, disturbed level of consciousness. The random blood sugar was very low. The serum sodium is very low. Potassium is very high. And when you have hyponatremia and high potassium, always exclude adrenal insufficiency. The cortisol was very low, the ACTH is high, and the aldosterone is low. So we have a case of adrenal insufficiency associated with ambiguous genitalia. What would you like to measure for this baby? What lab would you like to do? Thank you very much. Excellent. 17-hydroxyprogesterone was very high, and the karyotype came XX. And there was uterus and ovaries. And so the final diagnosis is a genetic female, although it was referred as a male with bilateral undescended testes. And this is a classical salt-losing congenital adrenal hyperplasia. So when you have hypoglycemia, hyponatremia, hyperkalemia, think of adrenal insufficiency. Hypoglycemia is corrected after hydrocortisone. Males with CAH present with normal genitalia, and therefore the diagnosis is more difficult. In females, there's genital ambiguity, and don't forget to respect bilateral undescended testes. When you have a baby with bilateral undescended testes, exclude ambiguous genitalia, work up. The unilateral is not that important. What about this 12-and-a-half-year-old boy who came with short stature and weight loss, pubertal arrest, darkening of the skin, hypoglycemia, short, and pubertal arrest? The cortisol is very low, the ACTH is very high, the sodium is low, potassium is high, and the rest were normal. What's your diagnosis? Spot diagnosis? Addison, thank you. This is Addison's disease. So Addison's disease is uncommon in children, but should be looked for. Suspected in a child with weight loss, fatigue, hyperpigmentation, and hypotension. Of course, the treatment is hydrocortisone and alpha-fluorocortisone. The extreme side of the story is this 5-year-old boy who came with weight gain, short stature, moon face, plethora, acne. And look at the chart. The child started to plateau the height. He's very short and gaining weight. So please respect any child with short stature and obesity. It's very important. And here we found polycythemia, lowish calcium, impaired fasting blood sugar, and there was loss of circadian rhythm with high AM and PM cortisol. So Cushing was suspected here and confirmed by a lot of tests. So the further suggestion is to do abdominal ultrasound, and look what we found, a mass in the right adrenal. And look how big the mass is and how dangerous endocrine disorders could be. And بيرن لي خلاص ممكن تدوني 3 دقايق زيادة واسطة بس 5 كاملين ما أنا مش عارفة أقول إيه. أوكي فتحوا إيه ده مش عارفة جنتلمان يا دكتور طول عمرك جنتل والله. After curing Cushing, the child lost weight and gained height. And look how the child looks like before and after the Cushing, not only the weight and height, but the mood as well. So pediatric Cushing is uncommon, but should be thought of. Any obese short child, exclude endocrine and syndromic obesity. But if the child is obese and told this is simple obesity. Now, let's go to the thyroid. This is an 8-day-old neonate. The TSH came high on neonatal screening, 14, and the ultrasound is normal. Would you like to give thyroxine or wait? Wait, yes. Because based on European Society of Pediatric Endocrine guidelines, if the TSH is more than 40, start treatment. If the T4 is low, TSH above 20, start treatment. And if the TSH is from 6 to 20, repeat again after 2 weeks and do ultrasound. Now, when we saw the baby 2 weeks later, the TSH increased to 22. Would you still wait or treat? Treat, yes. Another side is 7-year-old boy with short stature, weight gain, lack of concentration, sleepy, fatigued. He started to be short and gaining weight. His growth hormone stimulation test is low, the bone age is delayed. What is the missing investigation in that boy? Thank you, thyroid, yes. Thyroid function had low T4, high TSH, primary hypothyroidism, positive antibodies, so this is Hashimoto thyroiditis. And when giving thyroxine, he started to lose weight and gain height. So exclude hypothyroidism in any obese short child, assess thyroid function before doing growth hormone provocation because hypothyroidism could result in a false low growth hormone stimulation. Hashimoto is the most common cause of acquired hypothyroidism in children. Now, very fast to the parathyroid. This is a 7-month-old infant who came with tetany and carpopedal spasm, craniotabes, bowing, vitamin D prophylaxis is not given. The calcium is very low, the phosphorus is low, alkaline phosphatase very high, vitamin D is low, and the PTH is high, secondary hyperparathyroidism due to low calcium. So this is a case of nutritional rickets, and we started to see it very early due to osteomyelitic mothers. And these are the X-rays going very fast. And which type of vitamin D would you like to give to this rachitic child? Is it vitamin D analogs or vitamin D2 and D3? Yes, D2 and D3. There's no point in giving the active form of vitamin D in such cases. So infantile ricket is common, may present with hypocalcemia, secondary hyperpara, and the treatment is D2 and D3. Another story is a 10.8-year-old boy with bow legs. First cousin, خلص الولد ده بس. عمالة بفاصل أنا. Palpable sagittal sutures. Okay. He had a very low reabsorption of phosphate and serum phosphorus, so this is hypophosphatemic rickets, and the treatment is phosphate. آخر سؤال بقى, which type of vitamin D in this boy? This is hypophosphatemic ricket, D2 and D3 ولا analog? Analog, yes. مش لازم دول بقى, أنا I will end, مش لازم دول. عشان نلحق, بس كده. حذفنا هو بقية الحاجات. خلاص? I'm sure that there's a lot of endocrine stories that every one of you has got, and I hope you enjoyed the Zoom into the pediatric endocrine clinic. My conclusion is that endocrine disorders can affect all body systems. Sometimes it's vague. Try to avoid the pitfalls, and early diagnosis and treatment is very important because we see excellent results when we diagnose and treat early. And this is my final slide because this is how I feel when dealing with pediatric endocrine disorders. We should be very accurate and focused in diagnosing, treatment, calculating the dose, because it's really, really challenging but interesting. Thank you very much for your attention.
خالص شكر للأستاذ الدكتور رشا طريف أيقونة البيدياتريك اندوكرينولوجي، متألقة كالعادة. بنشكر